pace of innovation in medicine, especially, in surgery, it's just relentless sometimes.
It really is.
It's honestly challenging to stay on top of all the latest breakthroughs, all the new research, and that's really why we're here, right? To try and cut through that sheer volume of information and bring you the most, impactful, maybe surprising, and definitely the relevant insights.
Exactly.
We've got our hands on some truly fresh research from the surgical world, literally hot off the press from just last week. It's a summary compiled by Dr. Reza Lankarani called The Most Significant Surgical Publications from Previous Week.
And what's really quite remarkable about doing this deep dive is seeing how these studies, which might seem separate at first glance, they actually weave together.
Right.
They reveal the sort of current path of surgical innovation and patient care. So we're not just going to tell you what's new, but really try to illuminate why it matters. What are the implications for the future?
Okay, let's jump right into it then. Looking at this week's research, what's maybe one key finding that really changes how surgeons might think about even a common procedure, like an appendectomy, making those choices smarter, more tailored to the patient?
Yeah, it's fascinating, actually. There's a large study, over 4,400 patients looking at appendectomies. And it revealed something critical about a characteristic most people wouldn't immediately think of.
Yeah.
Subcutaneous fat thickness, TSF.
Body fat thickness influencing appendectomy outcomes. How so?
Well, they found that if a patient had a greater subcutaneous fat thickness, their risk of surgical site infection, or SSI.
Right, infection at the surgical site.
Exactly. For open appendectomy procedures, that risk nearly doubled, an odds ratio of 1.82.
Wait, hang on, so just measuring body fat can nearly double the infection risk in an open procedure. That's a huge insight for planning, isn't it?
It is.
What if they use a laparoscopic approach, the keyhole surgery?
And that's the really interesting part. For laparoscopic appendectomy, that same fat thickness did not significantly increase the SSI risk. The odds ratio was basically 1.09.
Wow.
And the difference in the actual infection rates, pretty stark. It was 24.8% for the open procedures versus just 10% for laparoscopic.
Okay, that's a massive difference.
It really tells us that measuring TSF, maybe even using, preoperative imaging like an ultrasound, could guide surgeons.
So you see thick fat, you lean towards laparoscopy.
Precisely. Prefer laparoscopy for those patients with higher TSF. It's a genuinely data-driven choice to improve safety quite significantly. It really makes you ask, how much more can we personalize surgery with sort of simple, measurable data like this?
That's incredible, using simple measurements for such a critical decision. So we've just seen how data can refine even common surgeries. Does this idea, the sort of less is more or personalized approach, does it also apply to much more complex, maybe life-saving procedures like a total gastrectomy for stomach cancer?
Absolutely.
Because that debate between open and laparoscopic, it seems to keep going, even for major surgeries.
Yes, absolutely. The trend is definitely clear there too. There was a propensity-matched study looking specifically at laparoscopic versus open total gastrectomy for cancer patients.
Propensity matched, meaning they tried to compare similar patients.
Exactly, trying to level the playing field. And the key finding was that the laparoscopic total gastrectomy, LTG, resulted in significantly shorter hospital stays.
How much shorter?
About half a day less on average, which, adds up.
Sure. But what about the cancer outcomes? That's the critical part.
Crucially, yes. The LTG maintained an equivalent lymph node yield.
Okay, so getting enough lymph nodes out for proper staging.
Vital for cancer staging and treatment, yes. And they showed no significant difference in complications or overall survival rates either.
So laparoscopy holds its own even in major cancer surgery.
In experienced hands, yes. The conclusion is that LTG is oncologically safe. So, connecting this to the bigger picture, findings like these really support adopting laparoscopic techniques more widely, especially in high-volume centers, for complex cancer surgeries. It shows you can get that balance right. Minimal invasiveness, but still rigorous cancer treatment.
And this preference for less invasive methods, it seems like it would naturally help reduce other complications too, like one of the really feared ones in bowel surgery, anastomotic leaks, where the joint leaks.
That's right.
What did the research show there?
Well, an anastomotic leak, AL, it's a significant and pretty serious concern. It happens in, a wide range, something like 1.2% up to maybe 16.7% of ileocolic resections.
That's a big range. What drives that risk?
The research highlighted some key risk factors. Patients on steroids, for instance, those with low albumin levels, so poor nutrition. And also individuals with penetrating disease where the Crohn's is sort of burrowed through the bowel wall. Steroids had an odds ratio of 2.1. hypolipidemia 3.4, penetrating disease 2.8, so significant risks.
And the surgical approach. Does laparoscopy help here too?
It does significantly. Laparoscopy reduces AL compared to open surgery quite dramatically. The risk dropped from 7.6% in open down to 3.1% in laparoscopic.
Wow, again, more than halved.
Exactly. So it really underscores the critical importance of preoperative optimization, really focusing on the patient's nutrition, getting those albumin levels up if possible, weaning them off steroids if you can, doing that alongside choosing the minimally invasive technique. That combination seems key to minimizing these major complication risks.
Makes sense.
And they also mentioned robotic surgery, showing promise for particularly complex cases, maybe taking that minimally invasive benefit even further.
Okay, so moving away from these major abdominal surgeries for a moment, let's pivot to some really specific, maybe more niche areas. What about something intricate like nasal reconstruction? Using rib cartilage, for example.
Yeah, it's actually quite striking when you look at it. Rib cartilage is still considered a kind of gold standard for certain types of rhinoplasty nasal reconstruction.
Even though it has known issues.
Right. That's what's interesting. A meta-analysis, pooling data from 6 studies, nearly 900 patients. It found a complication rate around 7–8%.
What kind of complications?
Things like the cartilage warping over time. That was about 42% of the complications reported. Infection, around 31%. The graft moving, displacement, about 19%.
Okay, so not insignificant risks, but still the gold standard.
Yet, despite those potential downsides, patient satisfaction was remarkably high, 92%.
Wow. Why is that?
It's likely due to its versatility, the sheer amount of strong structural material you can get from a rib. And surgeons are continuously refining the techniques. The study mentions things like balanced cross-sectioning.
Meaning how they carve the cartilage.
Exactly. Carefully carving it to minimize its natural tendency to bend or warp over time. That seems to be helping. But a clear takeaway is the need for better, standardized outcome reporting in future studies.
Right, so everyone's measuring success the same way. Okay, from super intricate nose jobs, let's maybe switch gears completely, to a really common, often quite debilitating condition, but where maybe surgery isn't always the first step or even needed.
Ah, yes. There's a fascinating study on a non-surgical approach for advanced hemorrhoids.
Advanced hemorrhoids, grades 3rd and 4. Usually that means surgery is on the table, right?
Often, yes. But this approach, called ToneFact, it's compelling because it directly tackles the underlying causes. Things like straining, low pelvic floor muscle tone.
So what is ToneFact?
It's basically a patient commitment protocol. T is for defecation, time keeping it under 5 minutes. ONE is for 100 Kegel exercises per day.
100 Kegels a day. Wow.
Yes. And ASCUS is for fiber, specifically 20 grams of psyllium daily.
Okay, so time limit, Kegels, and fiber. And the results?
Pretty impressive, actually. An 89% success rate reported in the study.
89% success in avoiding surgery for grade 3rd hemorrhoids.
That's what they found, yes. With 78% of the eligible patients in their cohort managing to avoid surgery altogether using this method, it significantly reduces the surgical burden.
That's genuinely surprising. Almost sounds like, well, like physical therapy for hemorrhoids.
In a way, yes.
It
directly addresses causative factors. But the key thing, the absolute linchpin.
Let me guess. Getting patients to actually do it. The 100 Kegels.
Exactly. Patient adherence is critical. It highlights that sometimes these simple, consistent interventions can work wonders, but they absolutely depend on the patient's dedication and consistency.
Makes sense. So, okay, we've looked at refining common surgeries, minimally invasive trends, specific reconstructions, even non-surgical options. What does this all mean for the really big picture stuff, the cutting edge? Let's broaden the lens maybe to organ transplantation. How's that landscape changing?
Well, looking at the future of transplantation, particularly liver transplantation, we're seeing quite a profound shift.
In what way?
The main reasons why people need transplants are changing. It used to be dominated by hepatitis C. Now, the primary indications are MAFLD, metabolic-associated fatty liver disease.
So, related to obesity, diabetes.
Exactly. That's about 34% now. And ALD, alcoholic liver disease, and 28%. They've overtaken HFE.
Interesting shift. And what about the technology?
That's where things get really exciting. Innovations like normothermic machine perfusion, NMP.
Keeping the organ warm and perfused outside the body.
Precisely. It's already reducing the number of organs discarded by about 20%, and it's allowing surgeons to expand the criteria to potentially use organs that might previously have been deemed unsuitable. Even in some cases, organs from patients who had certain types of cancer spread to the liver, like colorectal mets or cholangiocarcinoma.
Wow, really pushing the boundaries there.
Absolutely.
Yeah.
And the future vision discussed in the research is even more ambitious. It includes things like organ rehabilitation using perfusion, wider use of NMP, and even xenotransplantation using animal organs.
The pig kidney transplants we've been hearing about.
Exactly. With genetic editing tools like CRISPR potentially helping overcome rejection and address the huge organ shortage. It's this incredible blend of deep biological understanding and cutting-edge engineering.
And it must require huge teams to manage these complex cases.
Definitely. Multidisciplinary teams are becoming even more essential for selecting and managing these complex recipients.
Okay, so speaking of incredibly exciting innovations, that idea of organ rehabilitation or even creating new structures, that connects to another fascinating area, doesn't it? Tracheal reconstruction, building new windpipes.
Yes, that's another field undergoing a really major shift in thinking. Moving from, let's say, traditional structural repairs towards the frontier of actually regrowing or engineering new tissues.
How do we know this shift is happening?
Well, a bibliometric analysis basically analyzing citation patterns in the top 50 most influential papers showed something interesting. Historically, the field was dominated by work on structural techniques, like the pioneering work of Dr. Grillo. But the recent focus, the papers getting high citation density now, are clearly centered on tracheal tissue engineering, trying to create new trachea using cells and scaffolds.
So the research momentum has shifted. What's the quality of the evidence like in this new area?
That's a key point. Currently, the evidence for tissue engineering approaches is mostly level 4.
Meaning case series, expert opinion, not large trials.
Exactly. So while the field is clearly transitioning towards these exciting regenerative approaches, there's a real need for future work. Priorities include standardizing how these engineered grafts are made, and critically, conducting higher-level evidence studies, prospective trials, level 1 or 2, to really prove their effectiveness and safety long-term.
Makes perfect sense. You need the rigorous data as the technology advances. Okay, finally, let's bring it back from the far future maybe to something more immediate happening right now in the OR. Something that seems surprisingly simple, but apparently has a huge impact on outcomes. Who's walking in and out of the room?
It's actually astonishing, isn't it? How these seemingly minor operational details like door openings and the number of people present can have such a profound, measurable effect on preventing infections.
So what did the review find specifically?
An umbrella review looking at multiple studies on OR traffic and surgical site infections found that for every 5 door openings during a procedure,
Just 5 times the door swings open.
the risk of SSI essentially doubled, a hazard ratio of 2.0.
Doubled, just from opening the door 5 times.
Yep.
That's incredible.
It is. And personnel numbers mattered too. Operating rooms with more than 10 people inside had 3 times the SSI risk compared to those with fewer than 10.
3 times the risk just by having a few extra people milling about.
Exactly. It really underscores that patient safety isn't just about the surgeon's skill, it's a holistic effort. It extends far beyond the sterile field itself.
So the practical takeaway is?
Strict door policies, limiting the number of staff in the room. These are crucial steps to reduce airborne contamination. The review highlighted that nurses are often critical in enforcing these protocols.
Yeah.
And maybe technical solutions like airlock systems could help too.
It's a powerful reminder, isn't it? Sometimes the simplest changes, the things we might overlook, can have a massive impact on keeping patients safe.
Absolutely.
Wow. Okay, we have certainly unpacked a lot today. We've explored the real cutting edge from, patient-tailored appendectomies and tissue engineering, right down to who's walking through the OR door. Hopefully you feel equipped now with some of the latest insights hot off the press from the surgical world.
It really illustrates, I think, that progress in surgery isn't solely about brand new, flashy techniques. It's also very much about refining what we already do, understanding individual patient biology much better, like with the TSF factor.
Right.
And optimizing every single aspect of the care environment, even down to door openings. It does make you wonder, doesn't it?
Yeah.
As technology keeps pushing the boundaries of what's surgically possible, how will those fundamental human elements, team coordination, clear communication, just sticking to simple proven protocols, how will they continue to evolve right alongside it?
That's definitely something to think about. A great question to end on until our next deep dive. Thanks so much for joining us.